So I was tasked to talk about the, pulmonary hypertension, which is a huge subject on its own. And I really don't have any, disclosures about this presentation, but, this is really kind of like the synthesis of my own experience interpretation of the literature. And I think you all know that in pediatrics, sadly, we don't have a lot of randomized controlled trials for pulmonary hypertension or even some of the medications that we use in the neonatal or pediatric population. They're often off-label or based from, observations or anecdotal or derived from the adult population. So, we do the best science, the best practice and the best medicine, which is an art, with the best evidence that we got from the literature that we have currently. So that's what I'll try to bring to you guys today. So my hope is to define a bit more what pulmonary hypertension means, talk about certain clinical phenotypes that you may find either during the transitional period or even more chronically. And I'll try to make it kind of relevant for the pediatric population because you guys see obviously different shapes and forms of pulmonary hypertension. And obviously, you could do an entire fellowship in pulmonary hypertension. So we're going to try to grasp today just the big concept and how it can be relevant to your own practice in the PICU. So we'll talk a bit about management towards the end. But I'll start by asking you guys, maybe if you have like a little 10 seconds, and hopefully, I'm not making you sleep already. What's for you pulmonary hypertension? Can someone give me kind of a definition of that? I'll stop sharing just so I can see your faces.
The invasive measurement of pulmonary arterial pressure, is it more than 25? I think that's for older.
Yeah, to a context, or maybe to an extent that it will affect the RV function, where the pressure might be more than 20 or 25.
Okay, what kind of pressure? What pressure is? What does that mean, the pressure?
Pulmonary arterial pressure, I think, or pulmonary wedge pressure. One of them.
Okay, I'll go back to basics, because we're going to talk about what is a wedge pressure, what all these things mean. So if you go to the pharmacy and you take your blood pressure, okay, and the pharmacist tell you, oh, you're hypertensive. How did the pharmacist deduct that?
Based on the percentile, like the normal population blood pressure, and I would be more higher than their standard deviation of the normal, like, yeah.
So for example, let's say you do a blood pressure and your blood pressure is 170 on 70, let's say. Are you hypertensive?
Yes.
Based on which number?
The systolic of more than, yeah.
Yeah, so systolic. So when you talk about pressure, you have to remind yourself that the human body works as a pulsatile pump, and you have a systolic, you have a diastolic, you have a mean. So the cutoff you just mentioned, which is 20, not 25 as per the new standards, is actually a mean blood pressure. So if we go back to basics, the pulmonary artery, the same way the aorta, has a systolic, a diastolic, and a mean. And if you would take any patient that is about 3 months of age and has done already their transitional physiology, if you go to the cath lab and you put a catheter in their pulmonary artery, you're going to get a tracing. You're going to get an arterial upstroke, and then you're going to get a descent, and eventually you get a lowest number, which is called the diastolic blood pressure. And when the RV contracts, you get ejection again, and you get a peak systolic and eventually a diastolic. And it's actually the area under that curve that provides you with a mean, right? Whenever you do an integral of a curve, you do an average number, and a mean is an average, right? Now, because most of the time we spent a third of our cardiac cycle in systole and 2/3 in diastole, we often like average, a third plus 2/3 equal the mean. But really the mean is the area under the curve under the arterial waveform, basically. You kind of all know that when you put art lines, that's what we're looking for a mean. It's that area under the curve. So The standard definition that's been established by both the European Society and the American Society of the American Heart Association and the American College of Cardiology is that to describe someone to have high blood pressure in their lungs, in their pulmonary artery, which is pulmonary hypertension, you need to have a value of mean pulmonary arterial pressure above 20 millimeters of mercury. Now, a pressure is a function of what? How do you create a pressure?
The heart, like the pump.
Against the resistance.
So if
It's a resistance and, so it's a function of resistance and, what's the second part?
injection.
Volume?
A flow,
Flow.
a flow, right?
Yeah.
You need flow. A box that has volume going nowhere is not going to generate much pressure. So you need flow and you need resistance. So flow is generated by the RV, right? That's the pump. It's going to generate the flow, and it's going to generate the flow in order to go through all these vessels. And the downstream resistance is going to dictate how much pressure there is, right? Now, as the RV is going to face increased resistance, it's able to some degree to compensate and to maintain the flow, which ideally you want to maintain your QP/QS to be 1:1. That's what's going to lead to increased pressure. Now, if your RV fails and your RV becomes a flow and you're not able to generate flow, your pressure might drop, but you may have very high resistance, right? So if your flow goes down and your resistance stay high, eventually your pressure will go down. So it's a bit of a paradox, but if you have a patient that's coding, the blood pressure, the pressure in the pulmonary artery will be very low. And we still call it pulmonary hypertension, but it's actually a misnomer. It's high pulmonary vascular resistance or high RV afterload, right? And the problem of the disease or the symptom of pulmonary hypertension is that it can create end organ damage, and the end organ damage is actually the RV that's being damaged. And eventually, because you have low pulmonary blood flow, you end up with low left atrial preload. Because you have low left atrial preload, you get low LV preload. Because you have low LV preload, you eventually get low output. Because you have low output, you go into like a shock-like picture and eventually cardiac arrest because you cannot perfuse your coronary and your patient dies. So obviously the end result of severe pulmonary hypertension disease, and we'll go over what are the different categories of disease, is that you go in a low output state and your patient will become very gray and hypoperfused and eventually may die from that. Okay, so one of the key rules to remember, especially in newborns, and I guess it's the same for pediatric intensive care, is that a patient that is blue and perfused and sending still blood flow to their organ is better than a patient who's completely gray. Okay, right? And so unless you have shunts somewhere, a patient in a pulmonary hypertension crisis due to high pulmonary vascular resistance will be gray, will not be blue, right? To become blue, you need somewhere blood flow that's blue, deoxygenated, entering the systemic compartment. So let's go back to my presentation. Do you see my presentation? So what is pulmonary hypertension? It's basically a symptom, actually. It's defined as high blood pressure in the pulmonary artery. And we're going to go over certain types of conditions that can cause this. And obviously, you're not going to treat each etiology the same way. So for example, if I put a big clot here, and I measure the pulmonary pressure in the proximal pulmonary artery, my pressure is going to be extremely high if the RV is able to cope. Eventually, the RV is not able to cope and you go in cardiac arrest, right? Because eventually it copes by trying to bypass this clot and sending a bit of blood flow, which will perfuse the lung and fill up the LA. But at some point, it may not be able to cope. It cannot generate flow, and eventually you obviously get, a cardiac arrest because you have no preload and your patient may die. So having a clot here may not be the same treatment as a patient who has a severe LV dysfunction, and because of that, you get huge congestion, right? You're not going to do exactly the same. So the end result is the same, high pulmonary artery pressure. Your pulmonary artery pressure is rising, but the etiology is completely different. And the process for you to kind of figure out what's the cause of this RV failure and high PA pressure is going to be very important in dictating how you're going to treat these patients. You're not going to put INO on all these patients, right? Even if the PA pressure is high. Yeah. So the definition is high pulmonary artery pressure. Now, the caveats to that definition is which number do we give to that? So how are we going to define high PA pressure? So there's been many, many hundreds of patients in cohorts, both in pediatric and adult population that have been analyzed, and their data on Cath measurements of their mean pulmonary artery pressure was retrieved. And they found that patients who presented with pulmonary arterial hypertension, okay, so a pre-capillary, so before the capillary, so high PVR or very high pulmonary artery pressure secondary to like arteries that are very abnormal. They looked at these patients and they found that using a cutoff of 20 was putting you at very high risk of either mortality or lung transplant within the age of 5, like 5 years after the diagnosis. Now, this is true for a very specific category of disease. It's true for the category of disease that we call idiopathic pulmonary arterial hypertension or hereditary pulmonary arterial hypertension. And some patients with congenital heart disease that had some Eisenmenger physiology at that point to introduce in these cohorts. It's not necessarily completely true for all the categories of pulmonary hypertension, but what we know is having these values are definitely out of norm compared to the normal population, starting the age of 3 months of age. Before 3 months, you're still in that transition where the pulmonary vascular bed is still relaxing. So you cannot really rely only on a pressure measurements. So what we know is that by 3 months, your pressure in your pulmonary arteries should be about 15 of systolic, 5 of diastolic, and a mean of 10. And when you reach above 20, that's when you get a formal kind of, tag, you have pulmonary hypertension, but this is a mean. And when I do an echo, I cannot necessarily give you a mean estimate. What I give you an estimate is what we call the systolic. So that's why we often use about a systolic of 40, which is thought to reflect a mean of 20. But you have patients with systolic of 35 that have means above 20. You have patients who have systolic above 50 that have a mean that's less than 20. So that's why the echo is an imperfect way to measure pressure, because it doesn't necessarily give you the information, first of all, about the pressure sometimes, especially the RV is not vigorous enough to generate any regurgitation of the tricuspid valve, and we'll talk about this. But also it doesn't necessarily give you a mean pulmonary arterial pressure. So the classical definition of what we call pulmonary arterial hypertension is a mean above 20, the pulmonary arterial wedge pressure, LV and diastolic pressure less than 15, a high PVR, so this is arterial disease, and a transpulmonary gradient of more than 7, which means that the diastolic pressure between the lungs are more than 7 because the diastolic pressure is very low in the venous bed compared to the arterial bed. Okay, so that's arterial. Now, can someone explain to me what is a pulmonary arterial wedge pressure and what is an LV and diastolic pressure?
So LV and diastolic pressure is the easy, maybe one to say from the name. So it's the pressure of the LV at the end of that diastole. So you can see it through again a catheter.
Okay. So at the end of diastole, this is okay. Just situate yourself. This is the SVC, IVC, right atrium, right ventricle. You get the pulmonary artery. Some kids have also shunts like a duct, ductus arteriosus. Then you get pulmonary artery feeding the arterial component of the lungs. Eventually you get capillaries. You do your oxygenation, ventilation, and then you get venous drainage. And this venous drainage comes back into the left atrium, and then your left atrium feeds into the LV, into the aorta. Does that make sense? And then the cycle restarts. Now, some patients, especially newborns, may have communication that may offload or overload certain chambers, depending on the size of it, the restrictiveness or not. And some of them may not have any of these shunts. Okay, so we'll start by talking like a situation, there's no shunt. Let's say you have a patient that was operated for total anomalous pulmonary venous return, sutureless repair, come back at 3 months of age, codes in the emergency room, the x-ray is completely white, full like pulmonary edema, white out, of the lungs. And this patient is being resuscitated, and eventually there's an echo that's being done, and they say, wow, the confluence of the pulmonary veins has stenosed completely. So obviously this kid right now, which is dependent on pulmonary venous drainage return to the LA through this confluence, has now scarred down to a way that it restricts the flow in the pulmonary veins. So if I would take a little magic wand catheter and try to get the pressure everywhere, my LE pressure, unless I have a shunt here that would allow to feed that LA, my LE pressure is going to be very, very low because I have nothing that fills this LA. So this LA is completely underfilled, right? So you have an empty LA that's going to have very low pressure. By definition, two structures that connects themselves will equalize pressure. So during diastole, ventricular filling, the mitral valve is open, and so the LV and LA have the same pressure, which is generally very low. So if this is very low, during ventricular filling or expansion, you're going to have a low pressure in your LV. So when we do an end diastolic pressure, this pressure is going to be low, like 3, 5, something like that. Same thing for the LA. What if I try to measure the pressure inside my pulmonary vein? Is the pressure going to be high or low?
It's going to be high.
Very high.
It's going to be high. So one way to measure downstream pressure in order to get a sense of what's happening in the pulmonary venous bed is to introduce a catheter inside the pulmonary artery, block the pulmonary artery, and measure the pressure distal once I occlude my pulmonary artery and I don't get pulsatile flow through it. So it informs me on the venous drainage pressure. So if I have a high pulmonary wedge pressure, pulmonary artery wedge pressure, and I get a low left atrial pressure, I know that somewhere between my artery and my drainage, there's a problem.
Mm-hmm.
Whether it is venous disease or something like chronic thromboembolic disease with multiple showers of emboli that are blocking distally some of these artery to capillary junctions. So there is this disease, which we call chronic thromboembolic disease, and they can get millions of little showered emboli. And obviously when you get that, then your wedge is going to increase. And then it's for you to see what makes sense. What's the story of the patient? How does the vein look like? Do I get a CT scan? Am I in pulmonary edema? Pulmonary edema goes with, I have flow coming to my pulmonary vascular bed, and then there's spillage into the alveoli. So there's clearly something happening with the drainage there, okay? If I have issue with my mitral valve, severe mitral insufficiency, severe mitral stenosis, then obviously that's going to increase my LE pressure, my pulmonary venous pressure, and my wedge. But my end diastolic pressure will be low because I get underfilling of my LV if I have mitral stenosis. If I have mitral insufficiency, it will actually increase your end diastolic pressure because you get to and fro through the mitral valve. So it's like, so the LV will become very overloaded with volume, and it will create higher pressure into your LV, and eventually your LV will fail because of that. Same thing if you have significant LV failure, diastolic dysfunction, LV hypertrophy, stiffness of your LV, cardiomyopathy of your LV, restrictive, kind of expansion of your muscle wall. So think about patients who underwent at least in newborns, we have conditions like lupus disease of the newborn, like fetal lupus cardiomyopathy, or if you had like coronary ischemia, and because of that, you get fibrosis of your LV, and your LV becomes very stiff. Sometimes this stiffness of this LV will create issues with expansion of your LV, and because of that, you had high LV and diastolic pressure, high LE pressure, and eventually backflows to the lung, and it's going to rise your PA pressure. I see Farhan has a question.
Yeah, no, well, this is actually just, old guy stuff, but one of the things that our fellows should look for is when you're seeing the pulmonary edema, look at the heart size. And I've made this diagnosis twice in the past year and a half. When you see a heart size that's small and a lot of pulmonary edema, think left-sided inflow problems. So in one of them, it was actually pulmonary venous obstruction. with pulmonary hypertension on the basis of that. And the other one was a core triatriatum with pulmonary venous obstruction that presented like a total anomalous, a TAPVR. But just, take a look at the size of the heart. Remember that most with pulmonary edema are left to right shunt and a big heart. If you see a smallish average size heart, start to think about that as being your issue. And that's when you're going to think about that with that sort of clinical presentation.
Thank you so much, Farhan. That's such good examples. So we call often this phenotype like a post-capillary because it happens after you get an obstruction or issue with drainage after the capillary bed. And so you'll rise your PA pressure, you'll increase your wedge or your end diastolic pressure, depending on where the issue is. Typically, initially, your pulmonary vascular resistance will remain low because your vascular bed will try to vasodilate because it's sensing so much pressure, but eventually you'll start having constriction in order to adapt to this higher flow. And so that can lead to eventually down the road something that we call a combined pre and post capillary pulmonary hypertension, where they start having higher PVR. It becomes an issue when you start having that. And the diastolic pressure between what's happening before and after the lung are about the same. So if I just go back a bit into the pediatric classification of pulmonary hypertension, there are many causes of reasons of why you can have high blood pressure in your artery, in your pulmonary artery. You can have issues with primarily the lungs that are causing like issues with like CO2 retention, hypoxia, things like that. You can have transitional issue where your PVR has not dropped. Maybe your lungs are too small and you don't have enough pulmonary vascular bed. So there's a fixed component. You're not able to fill so much of the blood flow. You're trying to take the entire traffic of Montreal and Toronto to fit it in Laval. You don't have enough highways. There's a disease called isolated pediatric pulmonary hypertension. This is a disease where they get a multifactorial picture of their lungs, but one of the key elements of the disease is that they get progressive obliteration of their pulmonary vasculature. So although a lot of the treatments that we have right now are based on this disease, actually, to try to vasodilate the residual pulmonary vascular bed, at some point, the three vessels, they are dilated. So you need other strategies, okay? There's obviously pediatric lung disease, thromboembolic disease, altitude, or what we call hypobaric hypoxic exposure. And then there's other elements like genetic conditions, trisomy 21, BMPR2, TBX4, all these things that are a bit more kind of advanced, hypothyroidism, HIV, schistomiasis. There are other causes that you can see. So the classical, when we think about pulmonary hypertension, is what we call a pre-capillary or a pulmonary arterial hypertension. It's often an issue on the arterial side of things, whether it is a reactive high PVR due to various reasons, or whether it is a fixed PVR. And I wish that in our population of patients, we could classify that well, but there are diseases that have multiple elements to it. So I'll give you an example, CDH. They often have high PVR. They often have not enough vascular bed. They often have a mechanical compression effect. They often have a small LV. They often have pulmonary hypoplasia. They often have VQ mismatch. So on top of it, they get areas of the lungs that are just not ventilated and not oxygenated. So obviously, if you have like 30% of your lung that is receiving INO and all the rest is not receiving anything, you're never going to vasodilate enough of these lungs, right? So INO being administered inhaled. So it's all these elements you need to take into account when you manage your patients. Like, what's the phenotype that I have? What are going to be the strategies that I'm going to put in place? And what's my end goal? Like, what am I trying to achieve? Is it about oxygenation? Is my patient hypoperfused? Is it that my RV is failing? So these are the things that you need to think about when you address these patients. So this is an example of a patient who have high PVR or high pulmonary artery constriction. And because of that, they get high pulmonary pressure, systolic of 100, for example. And when you compare the RV systolic of 100 to the LV systolic of 65, you're clearly in a suprasystemic range. And so these patients, if they have a duct or they have a PFO, they might shunt through it, right? So if you would have a duct, you could shunt, and then some send some deoxygenated blood into the descending aorta, which would create differentials of stats. And if you have a right atrium that is under very high pressure because the RV is failing, you'll eventually shunt towards the LA and make the patient blue all throughout the body. And I mentioned that because in certain therapies, like end-stage pulmonary hypertension, you may create artificially these shunts if your patient is so critically ill. So there's something called a PUTCH shunt, which is actually a fake PDA. You basically connect the pulmonary artery and the aorta, a bit like a artificial PA window. And then some centers will actually enlarge foraminovalleys or ASDs to try to unload the RV that's failing in certain patients. Now, having these kinds of things puts your patient at risk of other complications that are beyond this talk. But these are things that, to think about. Embolus can present similarly. We spoke about post-capillary. We spoke about the post-capillary here. One thing I want to mention is that you guys deal a lot with congenital heart patients, and these patients may have also shunts. And one easy shunt to think about is like a duct, okay? So we often have a situation where we have post-tricuspid shunt, and this post-tricuspid shunt, no matter what, will create pressure transmission. So for example, think about a big duct, like very large duct. When you connect two structures and you put a connection in between them, you're going to equalize pressure on both sides. So typically, when you have two, like let's say, think about this patient. If you have a big PDA and you take your blood pressure in your aorta as 85/45, well, it's not surprising to see that the PA artery pressure in systole will be very close to that pressure in systole because you'll equalize on both sides. So pressure will become the same. We know that typically the resistance in the lungs are lower than the resistance in the body. So what's going to drive that? It's going to be flow. We just said pressure is a function of flow times resistance. So your flow is going to dramatically increase in your lungs. You're going to get increased QPQS. But if I would measure a pressure like by echo or by Cath, the pressure in the RV and the pressure in the pulmonary artery will be high by definition. But this is not a patient you're going to put on INO. You're just going to worsen the situation. You're going to drop further your resistance. The pressure not going to change because you're still connecting and equalizing on both sides. What's going to increase? It's the flow. So you're just going to worsen the amount of flow you're sending to your lungs. So when we talk about pulmonary hypertension, a patient with a large VSD and a patient with a large PDA, technically they have high blood pressure in their lungs. But it's not the same mechanism that because of a high PVR or a blockage or a post-tricuspid blockage, or a post-capillary blockage. So it's a situation where you have a big shunt that equalizes pressure and sends too much flow and pressure to the pulmonary compartment. I see a hand raised.
Yes, sorry, Dr. Latif. So just one question about the previous image. I just want to understand more the shunting physiology. If you have an ASD with an pulmonary arterial hypertension, so is it when you have an ventricular end-diastolic pressure that is higher than your atrial pressure is when you have your shunt, or is it the TR that is coming from the RV that is causing the shunt?
Excellent question. As afterload increases, let's say your RV, so we know RV will adapt postnatally. Typically, it's the systemic ventricle in fetal life, but it faces very low resistance, right? Because the system is parallel. You're connected to placenta. Placenta has very low resistance. So your RV faces the same resistance basically as the LV because of this huge PDA. And then there's obviously very high resistance in the lungs. So because of that, you get, the pressure on the pulmonary artery side and aortic side are the same. It's just the PVR are higher than SVR. So because of that, you get flow from your PA to your aorta in fetal life. But in wholesome, the resistance profile that the RV is facing is basically the same resistance that the LV is facing because they're interconnected. So it's the sum between the lungs and the placenta, and knowing the placenta is the majority of the vasculature, it's obviously a very low resistance system. So the RV is a systemic ventricle during fetal life. It does keep some degree of musculature in the first, during the fetal life, and eventually after birth, the RV starts remodeling and becomes a very smooth, very slim ventricle, used to very low pressure, very low afterload, so low resistance. And so if suddenly you bring your patient who's 4-year-old and you increase and jack up the afterload, this RV who was at the gym, you know, doing little 5-pounders, and you're telling them now you're going to bench press like 200 pounds, it's going to be a bit of a problem. So this RV who's trying to counteract the high afterload and who's been quote unquote deconditioned postnatally to be exposed to very high afterload is not going to be able to cope with that. So what's going to happen? It's going to start failing. And as it fails, you're going to start getting RV dilatation, acute dilatation. And with the dilatation, you get backflow. So you get your tricuspid ring that's going to start to dilate. Your right atrium is not able to empty in this right ventricle, which is overfilled and failing. So where's the RA going to empty? So either it's going to back up the flow into your SVC and your IVC, and you're going to get huge liver, edema of your lower limbs, big face, huge GVP. Or if you have a communication, depending on the size of this communication, you're going to be able to offload. And so you're going to maybe send various fraction of deoxygenated blood into your systemic circulation through this communication because of that, because your RA pressure will rise. The other thing that's going to happen is as the RV is not able to send blood flow into the lungs, there's much less blood flow coming back to your LA, so your LA pressure will fall. So the relationship between the RA and the LA pressure will favor right to left shunt if you have a communication. Does that make sense?
Yeah, clear. So it happens mostly during systole, the shunting right to left, right?
It could happen in systole and diastole. It could happen depending on the severity, right? Because in diastole, you open your valves, and if the end diastolic pressure is very high on the RV compartment, you might have a continuous right to left flow.
Okay, that's clear. Thank you so much. That was helpful. Thank you.
Okay, perfect. So I've put here for your reference the classification, the recent classification of, you know, the different types of pulmonary arterial or pulmonary post-capillary hypertension. I put also a little memo about shunt, but it's basically what I just explained right now, like what shunt will do either to pop off or pressure equalize between cavities. And we spoke about this. Now, the most common tool we use at the bedside is echo. Echo will help you mostly get an assessment of what we call systolic pulmonary arterial pressure. So we know in systole, RV equalize pressure with the pulmonary artery. If you have a normal heart, obviously, if you have TGA, it's something else. Your LV will equalize pressure with your aorta. And when you get an echo, sometimes when you get tricuspid regurgitation, you can get a sense of the gradient of pressure between your RV and your RA. So tricuspid regurgitation, I think I have an image here. Okay, it's basically blood flow coming back from your RA from your RV to your RA in systole. So normally you're not supposed to have blood flow coming back, and this flow generates a velocity, and this velocity of flow can be translated into a pressure gradient. So do you know what's the name of that equation? It's kind of written on the slide. Let me hide it. Anyone in the PICU room can tell me? It's a Royal College question, so you should all know it.
Is it Bernoulli?
So it's the modified Bernoulli equation. And what is the modified Bernoulli equation? How do you translate a velocity to a pressure gradient?
It's I had searched it before. It was one of my assignments that I did before, so I will give it for someone else. Thank you.
Are staff allowed to answer?
Yeah, sure.
4 times the speed squared.
Yeah, so it's the 4p squared. So basically, if you take the speed in meters per second, you square it times 4, it gives you a pressure gradient. Now, this assumption, it's called a simplified or modified Bernoulli equation because the real Bernoulli equation is much longer. It takes into account viscosity. It takes into account the two pressure areas. So we say it's simplified because we assume many things. One of the things we assume is that it is through a narrow opening. So as your opening becomes bigger and bigger, this assumption is not as true anymore. So, or if it's a tunnel, so for example, if you're applying this to the speed through a duct or through like a shunt, it might be not as true because you get attenuation of speed on the walls of a tunnel, right? Compared to a narrow opening. So just to say that, for example, if you have a TR like this, so here, if you follow this echo reading, you have an RV, an RA, and an LV, and an LA. You see this little blue jet, which means that blue is coming away from the probe, and it's at a time of ventricular systole when the valve is closed. I'm putting a line of interrogation through it to get something called a continuous wave Doppler. Continuous wave Doppler means that I'm obtaining velocities across this line throughout the line. So if I follow my ECG, I get my QRS, I activate my ventricular systole, my ventricle starts to pump, and eventually I get a speed, a peak speed of blood flow from my right ventricle to my right atrium. And so if I translate this 5.5 meters per second into the Bernoulli equation, I get 119 milliliters mercury. So it tells me that between my RV and my RA, I have a gradient of 119. Now we know that typically the right atrial pressure, if you put a central venous pressure catheter, is usually like 5, 6, 3, depending on the cardiac cycle motion, but it's typically low pressure. So we historically have been adding about 3 to 5 millimeters mercury, but we know that this is not true in patients with RV failure because their RA pressure is likely much higher than that. So it's probably like 10, right? Unless your RA is unloading into your LA, then obviously that, may be closer to 5. But just to say that even 119 plus 5, this is a very high pressure. So if you know that your aortic pressure, if you take a blood pressure on your patient and you're like 100/80 and you're already 119 or 125 of RV systolic pressure, you're clearly suprasystemic. Okay, so that's one way to kind of estimate what we call systolic pressure because this is in systole. Again, this is not a mean pulmonary arterial pressure, it's a systolic pressure. The other thing we often look is a relationship between the RV and the LV. So this is what we call a short axis, which means that you're cutting the heart as a short axis in the middle. You're looking from on top. Typically, the RV is supposed to be very crescentic, slim, not muscular. And when you see that your RV is about the size of your LV, and that during contraction, because again, it's in systole that the ventricle will equalize pressure with their outflow tract. During contraction, you see that the septum is either bowing or flattening. It tells you that, when it's flat, it's about isosystemic RV pressure. And when it's bowing, it's suprasystemic RV pressure. Now, whenever you're looking at a relationship between two chambers or two vessels, which is going to bring me here, you always have to ask yourself, what am I comparing to? So obviously, if your patient has extremely low LV pressure or aortic pressure, you might get a flat septum. So we see a lot of babies like preemies who have like E. coli sepsis and they have such low SVR that their blood pressure is like 20/10. Well, I'm not surprised to see that my septum is going to be flat because my LV pressure are just so low because the SVR are low, right? So it's important when you're looking at this septal curvature or the relationship between the RV and the LV systolic pressure, what is happening on my LV side? Is my LV pressure abnormally high and my RV pressure is even more high? Is my LV pressure normal, my LV pressure normal and my RV pressure abnormally high? Is my LV pressure very low and my RV pressure is high? Is maybe my RV pressure is normal, but it's my LV pressure that's low? So when it's a relationship or a denominator question, you always have to think about what's happening on the denominator side. So that's true for septal motion. It's true for VSD direction. It's true for PDA direction. So why PDA direction? Because if you have a duct, it can inform you on the relationship between the pulmonary and the aortic end. So if I see this is a pulmonary artery, aorta, ductus arteriosus, this is red, meaning coming towards the probe. So it's coming from the aorta and feeding into the pulmonary artery. So here I can assume that my SVR is likely higher than my PVR because I get complete left to right shunt. So it's feeding into my pulmonary artery. But maybe my PVR are high, but my SVR is even higher. So you have to put this into relationship of the clinical context. This is a bidirectional duct, blue, red, blue, red, blue, red. You have to see how much velocities you get. So this patient in systole, so if you look at QRS systole, you get 30 millimeters of mercury of gradient. So it tells me this PA pressure is suprasystemic in systole. When I look at this gradient, which is less than 1 meter per second, this is like very low velocities because it's a very light duct. It just tells me the pressure on both sides are probably about the same. But, you know, you have a concern here that you get some bidirectional component to it. And when it's right to left, well, it tells you that, you know, your PA pressure or your PVR are much higher than your LV pressure, your aortic pressure, your SVR. Now, you could see this pattern, for example, in a patient. So if I tell you which patient population you could see this pattern of right to left shunt with a restrictive duct, what could be potential etiologies for that?
You guys understand the question?
No, again.
Yeah.
Again,
So you have a patient, so this is an echo, you have a pulmonary artery, you have a descending aorta, you have a very, very small ductus here. It looks very turbulent flow through it. It has a high gradient, and the gradient is right to left, which means the PA is feeding into the descending aorta. And the gradient.
Hypertension, basically?
Coarct, maybe?
No,
Core, great. So pulmonary hypertension can cause a picture like this. Coarctation, interrupted aortic arch. So that's why it's very important. Like, it's one thing to see one clip of an echo and telling you, oh, the duct is right to left. It's another thing to try to put into the context of the whole picture. Like, maybe this patient doesn't need INO, maybe this patient needs PGE, you know, like, so that's why it's important to, you know, think outside the box. Okay. So babies and pediatric patient can have the same kind of, yeah.
Sorry, just to go back, like it depends where the cork is, right? Because if you have like a postductal cork, you might have the other way around, right? Like it depends which level the cork is.
Yeah, it's extremely rare to have a postductal or descending aortic cork. These patients will typically present very hypertensive in their upper limbs and very hypotensive in their lower limbs, with low, you know, no femoral pulses. It's typically something that actually is detected much later in life because they're usually less severe than the kind of ductal, which is the most common. So coarctation is often like, you get like coarctation at the isthmus, which is the area where the duct actually connects. And so these patients will have typically, the ductus will have closed even in these patients when you detect them. And obviously, you know, these patients need to go to either IR or interventional cardiology for dilatation, or they need a urgent surgery. Yeah. Okay. Let me skip this. I put here a list of some of the investigation you need to think about when you're seeing a patient, you're thinking of pulmonary hypertension. So obviously, you know, like your regular physical examination findings, you know, vital signs, trends, temperature, because hypothermia can cause you to have, you know, high pulmonary vascular resistances, capillary refill time, your physical exam, you know, your liver edge is quite important there. Are you cold to touch? Are you blue? Are you gray? Are you hypoventilated? And then you want to start looking at your other things. So when we assess these patients, we try to be as comprehensive as possible. Could it be an infection? What's happening with my lactate? Do I have NIRS, low values? What's my chest x-ray looking like? Do I have an ECG baseline? Do I have a new ECG? Do I have arrhythmias? So it's kind of all these things you want to put together, and the echo is kind of one of the elements to put into context. And this is the actual recommendation from the PH guidelines. When you suspect pulmonary arterial hypertension or pulmonary post-capillary hypertension, these are kind of all the imaging that you can go in a stepwise manner. But obviously, by the time you're there, you're probably like kind of in a chronic phase, you know, like HIV, chronic tissue disease, doing a chest CT, VICU mismatch, making sure there's no PE or chronic thromboembolic disease and things like that. So I have like 10 minutes left. I think you know some basic echo views, so I'm going to skip the basic echo views. And I just want to show you some example of clinical images that we see. This is a case of just a PPHN, so acute pulmonary hypertension of the newborn. This is a disease where they have a failure of transition in the postnatal life. They typically have a duct. They typically have a PFO. but sometimes this duct may be wide open, sometimes this duct may be closing or completely closed, and your clinical picture would be completely different. So in a baby, it doesn't mean you don't have pre and post ductal saturation differences, that you don't have PPHN, because if you don't have a duct, then obviously you're not going to have differential SATs, right? So so this is a picture of pre-capillary pulmonary arterial hypertension. They get high PVR, they get right to left shunting at the ductal level, and because of the RV failure, they get this blue jet bringing the oxygenated blood into the LA, often because the LA is underfilled because of poor pulmonary blood flow, and the RA is overfilled because of the high end diastolic pressure. So some of them are able to maintain to some degree their cardiac function. And so how we treat them is typically by using pulmonary vasodilators, and sometimes we need to add pressors, which have been shown to improve the pulmonary to systemic ratio. If the duct becomes restrictive and your RV is failing, that's when you start thinking of popping off the RV using like PG. So example is a very tiny PDA. So if you have a tiny PDA, your RV may start to struggle. You start having more and more TR, and you start having this RV dilatation, which is much bigger than your LV, and now you bow towards your LV, the septum, and you see the duct here is very tiny. So these patients, you're going to start them on PGE, and it's just going to pop off this RV, but your patient is going to be bluer, right? You're going to have less pulmonary blood flow, and you're going to have more shunting volume through your duct. Yes, Patricia.
Gabe, I see that you are talking about hydrocortisone. What is the mechanism there? It's yeah.
Very good question. We think there's many mechanisms. Part of it, there's a thought that there might be some degree, especially in newborns, of what we call relative adrenal insufficiency, where their adrenals might be immature in a sense that it's not able to respond to the cope for the degree of the stress, especially premature infants, which have very immature organs in general. And number two, a lot of the disease we see are things like asphyxia or sepsis, where they get adrenal hypoperfusion or adrenal hemorrhage. So that's one thing. In fetal lambs that are with PPHN, I don't know if I put the slide here. Let me see. Many different slides. So in fetal lambs, no, that's a vein of Galen malformation. Did I put hydrocord? Yes. Sentence decrease in epileptic. So it's been shown in fetal lambs of PPHN that actually hydrocortisone will upregulate the whole phosphodiesterase system inside the smooth muscle cells. And it's been shown that once you expose these lambs with PPHN to hydrocortisone, it potentiates the INO effect.
Okay.
So that's why it's been more and more used and studied in the neonatal population with PPHN, because it's thought to actually potentiate the effect of pulmonary vasodilators through the INO and sildenafil cascade. And that's work that's been done by Robin Steinhorn, who studied her entire life on sildenafil.
So it means that in one hand, it would enhance the systolic function of these patients, and the other, on the other side of it, it would be to allow them to vasodilate better the pulmonary circulation.
Exactly. So you reduce afterload to your RV, you increase your pulmonary blood flow, and you're able to cope with the stress by being better responsive to the catecholamines that the baby or the kid is producing, or that you're giving as an exogenous way.
Any use of it for pediatric patients with refractory pulmonary hypertension?
I haven't seen, but the one thing that I did, so a lot of patients talk about, if you've been obviously exposed to adrenal hormones before, then you're at risk of having more adrenal insufficiency, that you guys know. But I haven't seen the use of hydrocortisone, particularly in patients like outside of the newborn period. That I haven't seen. I've seen some centers using steroids for the lungs when they have like ARDS, like a sequence of ARDS that's causing issues with the pulmonary hypertension, like either DEXA or solumedrol, but I haven't seen like hydrocortisone as a molecule being used outside of the neonatal period.
Okay. Just we have
Yeah.
one patient with primary pulmonary hypertension NYD that
I know.
you know about him, and so I'm just
Yeah.
thinking, we are at this point, is there anything else that we should be doing for him thinking outside the box? Thanks.
Like the lung transplant or the PUT shunt. I don't know that there is
The
one that
lung
can be offered.
transplant, yes, the shunt, no. Yeah.
Yeah.
Anyway, but so glad to have you with us, really.
My pleasure. So I'll make these slides available. Let me just stop sharing. I'll make these slides available. I have a lot of, I don't know if you've used my website or seen my website, but I've put a lot of the resources in the section on pulmonary hypertension. So if you go, I'm just going to share, and I'm going to open here.
Yeah, can I ask you to have a part 2?
Yeah, of course.
That we would go through cases. For example, we would talk about different cases and because right now it's a lot of information and it's amazing, and we need to review the slides and the presentation to segment everything. But
Yeah.
it would be nice if we could go, for example, through cases and do the backwards route. Start with the case, go for the echo, talk about what we see, and go back to the physiology there. Yeah.
Absolutely. Yeah, it would be my pleasure. I can come whenever you guys want. I've put, because I see that we have only a few minutes left, on my website, neocardiology.com, if you go to the pulmonary hypertension section, there's a whole section on PH and pulmonary vein stenosis. And in here, there's, hundreds of resources on how to, and more advanced resources on pulmonary hypertension per se. And I did put, if you go here and you type PICU and you click teaching on pulmonary hypertension, I put a whole cases, my slides are there for you. I have a cheat sheet, if you have a PH crisis and you need to intubate, what do you have to think about? It's not just which agent for intubation, but you might want to start INO even before. You may want to start EPO in some of these patients if your lungs are completely, severe VQ mismatch or collapse and you're never going to reach INO to your lungs. The type of drug you may want to consider, what you're going to happen after your intubation, what kind of analgesia you want to start, things like that. So there is this, and then there's the guidelines from the American Heart Association and from the European Society, which has a lot of these tables that I've shown you with some of these definitions. And then there's just other articles that may be of your interest regarding PH, acute vasoreactive testing, and pediatric pulmonary hypertension classification. So as I said, PH can be a whole fellowship, but yeah, so hopefully you get enough resources to review the core concepts. But I'm more than happy to come back and do